All right, let's dive right into this explainer. Picture this. We're on the hospital medicine service, and it's time for high-stakes morning rounds. Today, we're presenting a comprehensive case to our attending on a complex but incredibly common clinical scenario, chronic kidney disease, or CKD. Now, we're not just going to stand there and rattle off lab values. No way. We're going to break down exactly what's happening inside our patients' kidneys, how we risk stratify them, and ultimately, how to build a bulletproof management plan.
So here's our rounding checklist for the day. First, presenting Mr. Alvarez. Second, the engine of CKD. Third, staging and risk assessment. Fourth, multi-system uremic complications. And finally, number 5, the management plan. We'll take this step by step to make sure we really nail the mechanics of the disease before we even think about prescribing a single medication.
Okay, Section 1. Presenting Mr. Alvarez, the clinical hook. Let's meet our patient and immediately anchor these concepts in a real-world scenario.
I'll be presenting Mr. Alvarez. He's a 58-year-old guy with a long-standing history of diabetes and hypertension, presenting with 2 weeks of fatigue and exertional breathlessness. When we examined him, his blood pressure was sitting pretty high at 158/94, and he's got this bilateral pitting leg swelling that he says gets worse by the evening. He's also noticed foamy urine, and he's waking up twice a night to pee. Now, looking at his background, diabetes accounts for a whopping 45% of chronic kidney disease cases, and hypertension drives another 27%. But check out his social history. He's got this really concerning habit of taking over-the-counter NSAIDs every single day for his knee pain. Literally, every clinical clue here is stacking up and pointing right at his kidneys.
But before we can officially stamp this diagnosis in his chart, we've got to look at the strict criteria. The absolutely crucial point here is defining what makes his declining kidney function chronic rather than just acute. And that requires that 3-month time frame or clear evidence of structural damage, like albuminuria. You really can't just look at a single isolated snapshot of his creatinine. You've got to trend it over time to see the true trajectory of the disease. Moving on to Section 2, the Engine of CKD, pathophysiology. Now that we know his symptoms and the criteria, let's dive into the why and look at the microscopic engine that's actually driving his disease.
This brilliantly illustrates the vicious cycle of glomerular hyperfiltration. Honestly, no matter what the initial injury is, whether it's Mr. Alvarez's diabetes, his high blood pressure, or all those NSAIDs, the story is always exactly the same. That first insult destroys a chunk of nephrons. To compensate and keep the overall filtration up, the surviving nephrons basically have to work overtime. They adapt by cranking up their individual pressure. But over time, this hyperfiltration becomes totally maladaptive. It eventually injures the podocytes, those delicate cells making up the filtration barrier, and that causes fibrosis and even more nephron loss. It is a relentless, self-perpetuating engine of scarring that's going to keep going even if you magically cured the initial cause today.
All right, Section 3, staging and risk assessment, running the numbers. Stepping back from the cellular level for a second, let's figure out how we quantify Mr. Alvarez's exact risk level to present to our attending.
Based on his labs, Mr. Alvarez's estimated GFR is currently 38. If you look at the GFR axis, this places him firmly in the G3B stage, which spans from 30 to 44. But hey, GFR is only half the story here. The other axis is kidney damage, specifically albuminuria.
The KDIGO grid beautifully synthesizes both of these axes. When we map his G3B GFR against his severe A3 albuminuria, which means he's spilling over 300 milligrams of albumin per gram of creatinine in his urine, we can visually see that Mr. Alvarez lands squarely in the very high-risk red zone. And listen, this red zone isn't just a gentle warning. It independently predicts all-cause mortality, cardiovascular death, and a rapid slide into kidney failure. This is exactly why we have to measure albuminuria in everyone at risk. It drastically changes the severity of our entire clinical picture.
Next up, Section 4, multi-system uremic complications when the kidneys fail. Since we've established his high-risk status, we absolutely have to turn our attention to the multi-system complications that pop up as waste products accumulate in his bloodstream.
As that kidney function drops, patients develop uremia. This right here is exactly why we have to examine the whole patient. Uremia isn't just a localized kidney issue, it's a massive, systemic toxin buildup. It affects the brain, causing encephalopathy and restless legs. It hits the heart, leading to pericarditis. It affects the skin with intense pruritus or even calciphylaxis. And it completely messes with the blood, causing platelet dysfunction and bleeding. So,
Taking this back to Mr. Alvarez on rounds, while our patient is showing early hints of this, like the fatigue and the edema, we need to monitor him super closely for late-stage uremic symptoms. I'm talking about things like a metallic taste in his mouth, severe nausea, or uremic fever. These advanced symptoms are massive red flags because they often trigger the immediate need for dialysis. Now, right now, he isn't overtly uremic, but make no mistake, we are absolutely on the clock.
Beyond uremia, another huge complication he's facing is a normocytic anemia, and this is driven by two converging mechanisms. First off, his damaged kidneys are failing to produce erythropoietin, or EPO, meaning his bone marrow just isn't getting the signal to make red blood cells. Second, chronic kidney disease creates this chronic state of systemic inflammation that spikes a protein called hepcidin, which essentially traps iron in the body and prevents it from being absorbed or used. It is a nasty double hit of functional iron deficiency combined with low EPO.
Let's move forward and see how this builds into the mineral bone cascade, which is another massive complication we've got to manage. As the GFR falls, the kidneys fail to excrete phosphate. All that retained phosphate eventually triggers a crazy complex feedback loop. It spikes FGF23, which in turn suppresses vitamin D activation. Without active vitamin D, serum calcium drops. And what happens when calcium drops? The parathyroid glands go into absolute overdrive, causing secondary hyperparathyroidism. Ultimately, this pulls calcium right out of the bones, leading to renal osteodystrophy, and, even more dangerously, it dumps that calcium straight into the vascular system.
All right, final stretch. Section 5, the management plan. Therapeutics on rounds. Let's translate all of this pathophysiology into a concrete, actionable plan for our attending.
When we present our plan, our management strategy needs to be distinctly split into two parallel goals. We really can't just do one or the other. Goal 1 is slowing the disease progression to protect his remaining functional nephrons. Goal 2 is aggressively treating those metabolic complications we just went over, like the anemia and the mineral bone disorder.
Tying our management directly back to that hyperfiltration engine we saw earlier, our best drugs actually work by lowering that dangerous glomerular pressure through two very distinct mechanisms. ACE inhibitors and ARBs work downstream. They relax the efferent, or outflow arteriole, which immediately drops the pressure inside the glomerulus. Meanwhile, SGLT2 inhibitors act upstream. They basically restore tubuloglomerular feedback, which is the kidney's own internal pressure sensor. This eases the hyperfiltration before the blood even enters the capillary tuft. Combining these mechanisms gives us incredible protection that goes way beyond just lowering his systemic blood pressure.
Now, to avoid common pitfalls on the wards, we've got to remember some incredibly practical rules for our attending. Remember Mrs. Chen in bed 6 who panicked over her creatinine bump last week? Well, when we start an ACE inhibitor or an SGLT2 inhibitor, we're intentionally lowering the pressure in the kidney. Because of that, a small, transient dip in eGFR or a creatinine rise of up to 30% is completely expected. Do not panic and stop the protective drug. Second rule, if we prescribe phosphate binders, they literally must be taken strictly with meals, otherwise they just don't work. Third, when we're treating anemia, we actually do not want to normalize hemoglobin to a healthy adult level. We aim for 10 to 11.5 because outcomes are actually worse if you push it higher. Fourth, any CKD patient over 50 needs a statin, period. And finally, take Mr. Davis in room 12. If a patient is approaching advanced stages, we must fiercely protect a future access arm from day one. That means absolutely no unnecessary IVs or subclavian lines on that side.
So, wrapping up Mr. Alvarez's presentation for morning rounds, here's our definitive plan. We're going to optimize his lisinopril to drive that 158/94 blood pressure down to our strict target of under 120/80. We'll add an SGLT2 inhibitor to further protect his nephrons, making sure to fully warn him and the nursing staff about that expected initial dip in his kidney numbers. We're also adding a statin since he's over 50. We will absolutely stop his kidney-destroying daily NSAID habit today. And because he's in that G3B high proteinuria red zone on the KDIGO grid, we're placing an immediate referral to nephrology.
I'll leave you with this final, kind of provocative thought as we finish up our rounds. Roughly 15% of U.S. adults have chronic kidney disease, and honestly, a lot of them are totally undiagnosed. But the really shocking reality here is that most of these patients will never even reach the point of needing dialysis. Instead, they will tragically die from cardiovascular events first. Given that cardiovascular disease is the true primary threat here, shouldn't we view the kidney not just as an organ failing in isolation, but as the ultimate, flashing warning light into a patient's entire cardiovascular future? Are we treating that warning light aggressively enough? Think about that next time you review a metabolic panel.